It through the app actually.
So it's not sitting right over.
I'm gonna pull up.
Oh, you get to make it? Not yet, but he's going to the table and like. Well, it's awesome because there's a bunch of like berries on sale, like so it's like perfect. Time overlaps with last time I was at Kroger, I was there to get like very specific things. And
Oh,
like,
okay.
if I even start going to the Kroger, it's gonna get
Ready
in a while. Yeah. Yeah. I like the very specific. I'm excited.
Okay, guys, last GHICC of the year, small group. How does it feel? Overwhelmed with excitement, I see. How many of you are going to be traveling between your first, second year? Some folks. Okay, awesome. So, are there any non-GHICC people that are here? Non-GHICC? No? Okay. Okay, awesome. Welcome.
Any non-what?
Non-GHICC folks.
What is that?
So, the Global Health Interprofessional Workforce?
Oh, no. I think that's all.
Oh, that's all you guys. Okay, because we might have some folks straggle in that are not normally part of this group. Today's session, we're going to look at medical volunteerism and how to kind of develop cultural humility. I'm going to kind of go through this one. One of the things about global health and global health practice is it requires you to be incredibly self-reflective and have a very good idea of what your own motivations are, what your impact on local populations can be, and just be very mindful of the impact of your presence. So we'll talk a little bit about that. Cultural competence is a word that is probably in all of your course objectives for every health professional school. We've kind of gotten away from the idea of cultural competence a little bit. This is a quote that kind of describes what it is. It's culture acts as a template for the organization of social psychological processes, much as the genetic system provides such a template for the organization of organic processes. So we all have our own individual lens with which we see the world, right? We bring with us kind of our own baggage from our own personal experience, and also the cultural lens that we come from as well. So this is kind of a construct, a way of being able to understand how different perspectives impact impact the way that we interact with each other. And the idea of cultural competence is we all come with our own perspectives, our own biases, and that can come into conflict with the culture that you're going to in global health settings. And that's not only the culture in terms of a new country, it's also culture in terms of the culture of medicine. It's very different in other places. For those of you that are in other health professions, there's a low degree of differentiation. So anytime someone sees someone in a white coat, they assume it's a doctor. If you're a student, they assume that you've already had all your training. So there's also the difference of culture in medicine as well. You'll see this even when you're in the clinicals here at UTMB, that how the ideals that we want you to aspire to may not be what you see in the clinical setting. So we also have our own culture of medicine here. And then also the individual culture of the country as well. And these three things interface with each other, and having an understanding of that is called cultural competence. The problem is a lot of the way that cultural competence has been taught has been a little stereotypical, right? So it's a sense that if you know the parameters of this culture, then you know what to say, you know what not to say, you know what to do, that all you need to know are the guidelines of the culture and you'll be fine. But there's a lot of heterogeneity in culture. I mean, we're all a part of the American culture, right? I'm pretty sure we can find 10 things to disagree on right now. So just as there's differences in our culture, there are differences in other cultures as well. And part of being a global health practitioner is to be aware that we see the world not as it is, but we see the world through our own lens, and to be cognizant of that. I'm going to go through this a little bit. So this is a video talking about cultural competence. And what I want you guys to do is think about what pieces of this resonate with you and what pieces do you think are a little BS. Why does it keep doing that? Okay.
Oftentimes, when people are first learning about the field of cultural competence, they think their job is to learn about the food, the traditions, the holidays, the dress, the rituals, the religious customs of different cultures. And that stuff is important, but it's not the only part of cultural competence, and it's not the most important part. I think the most important part of cultural competence is something that I call managing your prejudices. Everyone is prejudiced towards some other group of people for some reason. Some people are uncomfortable with those that have darker skin or lighter skin, or people who are fat, or people who are too skinny, or people who don't dress well, or people who wear high heels. I'll tell you what mine is. I often feel uncomfortable with people that have purple mohawks and multiple body piercing. And in fact, when I come across someone like that, I feel really uncomfortable, and in fact, in the words of my 11-year-old daughter, they really creep me out. So when I'm asked to work with someone who is like that, I'm somewhat incompetent, I'm ineffective. It's hard for me to engage with them, to treat them fairly, to listen to what they have to say seriously. And I think that all of us will have some experience like that with some group of people. So what I tell people is that you will never get rid of that feeling towards another group of people. Perhaps if you were in psychotherapy for a number of years, you might feel more comfortable with someone that has purple hair, or that's very obese, or that wears high heels, or whatever it is, or someone who has darker skin or a funny accent. It may take you years to kind of get rid of that feeling. But what I tell people, in order to be culturally competent, what you need to learn to do is to manage the feeling, is to manage your prejudices. And that starts with being honest with yourself. You know, something about that group of people that I'm not comfortable with. Be honest with yourself. And then learn to try to not trust that feeling, or not pay attention to it when you're responsible for treating that person fairly, when you're responsible for listening to that person. Certainly if you're a healthcare provider and you're trying to engage with that person so you can understand their medical history, so that you can give them medical advice, you need to do so and kind of put your feelings of prejudice aside. I think when people try to ignore those feelings or they try to deny those feelings, they're actually more likely to get sucked in by them. And it's better just to be honest with yourself. I don't like that group of people. I don't like people that have an accent, or I don't like people that have that color skin or dress that way. And if you can be honest with yourself and say, oh yes, that's the feeling that I have whenever I'm with that group of people, and then manage it. Put it aside and say, okay, I'm a professional, and I need to interact with that person in an effective manner. I need to get a full medical history from them. I need to talk with them about a diagnostic and treatment plan. I need to schedule an appointment. I need to talk with them about their health insurance status. Whatever it is, in a healthcare environment, you need to be able to engage with people, those you feel comfortable with, those you don't feel comfortable with. If it's a group of people that cause you to feel prejudiced, you simply have to manage your prejudices, put them aside, and try to interact with that person in an effective way anyway.
So I'm going to prove some things to you.
Okay. What do you guys think of that? Yeah, she seemed to make it sound like it was static and there's not much you can do about it. You need to stop what you're doing and spend years and years in therapy. Have any of you had the experience of having had a bias that then was confronted or changed during your lifetime, or a family member or friend that changed the perspective?
Mine's simple, but my family is very anti-tattoos, and I have a lot of them. And my parents have always been like very anti-tattoos, but I think just like and I'm from California, so kind of like everyone around me has a lot of like tattoos. It's not really a big deal, but growing up it was like if I had like a double piercing in my ear, like I would have been thrown out of my house. And I got like a half sleeve. So that was like a little scary, but I was like out of the house paying for my own stuff. So, but my parents were very like, I was surprised because my parents were very like respectful of my decision, like your body, and my mom actually like wanted to help me like pick what color I was gonna get next, and very like, because as like a female, she was like, I want you to love your body and like love what you're doing. So, and I wasn't expecting that kind of reaction. I thought it was gonna be like, why would you put that ugly stuff on your body, which was the typical reaction my whole life. So. And on top of that, I was very nervous coming here from California. I still hide it in all of my classes. So I still like wear sleeves and long sleeves in all of my classes. Like I have every classes now that I have tattoos because that's good. So I feel like that's still a thing that people love and go like, oh, that's trashy or that's whatever. That's not professional. Whereas I know that when I go back to California with my master's, that's never something that's seen as unprofessional, whatever, that's just like, that's who you are, kind of thing. So I'm still like hesitant about that because I know that a professor might think that I'm not gonna be as smart or as whatever because I'm just so that's something I struggle with here.
And that's something that, I mean, you mentioned a lot of cultural issues. One is like really the culture of Texas and of UTB and professionals in Texas and maybe some of the biases that we have here versus the culture of California. Same, we're under the same flag, same nation, but there are these differences. And then also a surprising, I guess, shift in the way that your parents responded to you. That it's also very different when it's like somebody else who's getting a tattoo, when it's like it's your daughter. You know her, and they can empathize with you at a level that they might not be able to with somebody else. So,
Using the work environments is going to be a big
I was working and today and had like a polo on and you just see my tattoo with ink on it, it wouldn't have been a big deal at all. Because a lot of teas that I work with didn't get shadow in there. Tattoos wasn't a big deal for us. I don't know. So, like, I still have to write that line when I wear skirts, I still write on the same and things like that, so I still don't know what's basically so.
Thank you for sharing that. Anybody else?
I mean, I grew up here in Texas, and I remember throughout high school and college, which always would say, like, very specifically how you have to look. Like, I remember they were always like, you have that too, you have it. And I have like an afro thing here, and it's like, I cannot wear my afro because somehow find a way to pull it down or tame it. They're like hairstyles that just were not professional. Now, like, that I'm further into like high school and college, seeing a little bit of last year, I guess that's what it is, towards like hairstyles and that parents and healthcare professionals, which really goes back to the culture of like their actual profession as well as the area that you live, personal kind of thing. Yeah, I feel like those are really
And I think there have been in the armed services a big push to make sure that the standards of dress and of hair are not these like weird, unattainable ones where you have to like how in a combat zone are you going to relax your hair, you know? So I think that some of those biases that are definitely like Western-centric, Caucasian, that have infiltrated these institutions, I think we're getting at a place where we can look at those and say, you know, there was a history that informed this, and this isn't matching with reality. So we need to change those standards. So anybody else, you know, what about stories of parents? Have all of your parents stayed exactly the same? They haven't changed at all? No, all growing up, they're the same. I'm going to pick on you because you shook your head no.
You see, like, it's like, kind of like, sorry, what's your name? Lauren. Much like Lauren's story, like, there are a lot of things growing up my parents are like, very staunch about, and then as I got older, it's like, I realized there were much more thoughts about certain things or certain stances that I thought were very fixed. I guess much like Lauren's story, like, for example, my parents, when I was like, yeah, relationship pierce their ears, blah, blah, and my little brother went and pierced his ears. At first, like, mom was just like, this was a little, like, upset because he didn't tell her before he did it, but I mean, she's totally, like, over it now, which, I guess, just kind of goes to show people change, especially when it's about, you know, people who are close enough. And I mean, just there are lots of things that my parents changed about. I mean, and again, I guess going back to culture, they're immigrants, too, first generation immigrants, so there are lots of things that changed between when they were growing up in Nigeria versus when they first moved here versus now spending more than half of their life here. Like, a lot of the things that just they interpret and understand and how they like perceive the world has changed dramatically from my life when I was there. And it's same goes for religious as I to things that I was raised to think or believe positive of my own beliefs, and some of them are just like this process of this.
So we don't quite buy these things are static and they don't change, right? Okay, because human beings have an immense capacity to grow and to evolve. Anything else that she said that did or did not resonate with you?
The thing she said at the end about like being aware of your like biases and just like made me think. I was like special ed and minor in undergrad. They talked about a lot about like color blindness and how like so many people like, oh, I'm colorblind because of color, how that's such a like negative thing. I need recognize everybody's differences. Like that was a positive thing she pointed out. Like being self-aware. Like I feel like self-awareness is so important. And like us as like health professionals being self-aware, like I feel like that's the only positive part of that was like being self-aware of like our biases or prejudices, like catching ourselves so that we can be self-aware when doing evaluations or assessments or whatever. So like that just made me remember the whole colorblindness and making sure we just do backgrounds.
So the nugget of wisdom was self-awareness.
Yeah.
I think it's important because I can think of like personally, I've like experienced this just in some observations I've done. Like I have a really hard time with relationships where like the male is more like predominant than the female. Like the female is not really able to like have as much of a role, and in some cultures that is how it is. And so like I realize that so like going in, I have to have a mind shift because like if I'm talking to a patient and I'm wanting the female to answer, but the male is doing the speaking, that like irks my nerves. I'm like, no, like let her, you know. But like, there's also like a cultural competence of it of like that is their culture, and like he is the one that's like speaking for her, and so that's just like a personal one that I know that I struggle with.
You're probably not the only one in that.
Yeah.
You know, because kind of regardless of your background. I feel like we, as Americans, are much more sensitive to those things, and we notice it more.
Right.
And so it's hard when you have your own kind of beliefs of how empowered women should be, and then you're in a setting where clearly somebody isn't, but it's in the context of their culture, like they're very happy with, you know, the way that things are. It's hard not to kind of push our own like agenda on them. So I think that's a really good example.
Our training also tells us to like interview the patient, you know, when they're confident to do something. So like I totally have seen that before, and the first time I understood when I was watching, I was like, wait, that's the patient. Like, why are you talking to someone else? Right there is the answer. And then it was because the provider was male, and the patient was female, and the male companion was there. So the physician had to talk to the male. Even though he was like, you know, patient was very excited about that. At first, I was like, what's going on? And then I realized afterwards.
Yeah, it can be very disorienting, especially if you don't know that going in. But that's predicated on you being aware that, okay, I'm going to have this feeling that I need to pay attention to and kind of manage the difference in my worldview from the difference in someone else's worldview and be able to see it without judging it. Because I think it's hard not to judge, right? Because we judge all the time. But I think that's the thing, is when we do start to judge, it reinforces those biases and it creates them. Any last thoughts before we continue? Any other nuggets of truth that you were able to glean from that, or anything controversial that you thought, nah, I don't think this is right for us?
The only thing I've added to the self-awareness is to then, you know, allow that self-awareness to spur curiosity to further understand like maybe why you have these thoughts and how to dispel them. So usually I know the common thought is that if someone has kind of this group or whatever, is to further expose yourself to it and break up like that stereotypes. No stereotype and just over generalization is very exceptional. So usually that's what I prefer, or is the best way to approach it. So rather than just managing it and like dealing with the situation, develop a sense of curiosity to be like, okay, why do I feel like that? Let me learn more. And from there you might realize, oh, like I was totally off base, or you don't necessarily have to have that many feeling.
Yeah, and I think that that's part of having the insight of understanding that there's a bias that's emerging, and sometimes you don't even know, and then sometimes it's very present. So, and I like your comment because that's where I was going next, which is what do you do? How do you go beyond managing it and move to actually understanding So does anybody have an example of something that they've done like that in their own lives? Anybody willing to report on their own biases here? Gosh, nobody has biases. Okay. Can you think of examples of how, if you notice there's a bias, what you could potentially do about it? Like kind of a concrete example. I could stay here all day.
I had a bias against parents who don't vaccinate
That's a big one.
I just immediately thought they were like, oh, vaccines cause autism and stuff. And I was like, I didn't say anything, but I was like silently judging. And then I like, realized she didn't know why that kid needed these vaccines and why all of them at this time as opposed to later. Like, it was from lack of education. And after, like, the doctor explained to her, oh, she was more receptive to it. She was like, okay, yeah, we did this. And, like, there's other reasons, like, maybe they can't pay or they don't have insurance and stuff like that. It wasn't just the autism thing that a lot of the anti-vaxxers are here for. So, my, like, going into the next patient encounters onwards, I was, like, more open to the idea that there's other reasons, right? Mostly about the educational area.
So you could, knowing that you're about to encounter an anti-vax family, you could go up with like shields raised, like ready to attack, right? Because you know it's going to be an uphill battle. But you're doing that based on assumptions. And instead, you guys were actually able to talk to the parents to figure out what informed that. And were able to impact the health of that child, which is great. But how many of us, when we go in and we see, okay, it's a non-compliant patient, or it's an anti-vaxxer, or it's like this person hasn't ever been taking their medications, like we don't go in with the same kind of spirit as when we're going in to see somebody that we think is a compliant, like perfect patient, right?
I think that's seen all the time, like just in our society with people who are overweight or obese. There's like a very quick judgment to be like they're lazy or they're not doing anything about it. And it's like if you stop and talk to the person, like what type of like maybe health issues do they have, or mental health, or there's so much of like unseen, but it's very quick to make that sort of judgment. So that's just one of the things that I think is like, if you're not like educating yourself and you're not sitting down and having conversations with the person, it can be very easy just to like make a harsh accusation, which I think happens a lot in our society, unfortunately.
So how do we quell that desire to want to judge someone based on what they do or what they look like, or what do you guys do to consciously kind of decide that you're going to instill new thinking patterns?
Usually just look back on like stuff that I've done, or and I'm just like, am I much better? And I think that's just a good way to humble yourself.
So judgment is something that that creeps up in global health settings a lot, and in the end, a lot of cultural competency and humility is kind of your approach. You know, are you going into it with the approach of like being open to being changed by the experience and learning about yourself, and when you start feeling uncomfortable and walking towards that discomfort? And that's something that I don't think is something unique to global health. I think that's something that that benefits us here as well. It's something that we encounter that might be a little bit even more insidious here because it creeps in without you really being fully aware that it's happening. So we're going to watch a little bit of a video that was made by some of our colleagues at UCSF in a collaboration with, I want to say, University of Toronto. And they're going to go through, I don't even want to call them health workers because some of them are undergrad students. But I want you to put yourself in their place. And I want you to think, what was surprising to you? How did it make you feel? And what would you have done if you were in that situation? This tends to be a little, medicine-centric, but you can apply it to pretty much any setting.
Africa, a continent of untamed wilderness, colorful cities, enigmatic cultures, heartrending poverty, and more volunteer aid and development organizations than almost anywhere else in the world. With Western media as our guide, Africa is often reduced to a homogeneous set of photo ops with endlessly grateful men, women, and children who simply couldn't go on without our $15.95 a month. This is a stark contrast to our other Africa of $600 a night safari lodges and several $1,000 treks up Mount Kilimanjaro. Many of us in the West understand Africa and other developing regions to be simultaneously intriguing and in desperate need of help. Volunteering becomes an adventure with the bonus of feeling we've done good. Health professionals can be particularly susceptible to this volunteer tourism. So, medical tourism has multiple meanings. It can be anything from, we see in the media where people are going to location A to have surgery, for example. But it also can be students or faculty who are going for a quick time to do clinical work. Increasingly, medical students and aspiring medical students are seeking opportunities to become involved in global health. This isn't surprising, as many students want a career in medicine because it's a profession of helping. But in an overwhelming desire to do good in the world, the presumption that, as medical students, we can help may be naive at best and detrimental at worst.
Come and see how we can work together, but don't come to try to change us overnight. You won't do it. Some feel that if they go back and collect someone and send it, it will solve the problem. It's a little bit bigger than that. They will solve the health insurance problem by collecting someone to health. And come and work with us. We have issues, limitations and challenges, but look at it in a way where you can add on and step at a time. And sometimes you're adding on is recognizing that Africa is out there. It needs a little more than what we have. One day when you are older, when you are more influential, when you are consultant, look at a way you can come out and help Africa.
Part of the reason I come to Africa is because I always wanted to go here as a tourist. So it did play into a lot of the interesting programs went to South America as well, but I've been there in the past, and I've always wanted to go see Tanzania and see Kenya. So it definitely was a factor within my choice to come here.
Honestly, I think my reason was probably more selfish than Liz. I wanted to come to Africa, and I wanted to volunteer. And I think everyone who is doing a medical placement here has to admit a little bit that it looks good on a resume. So, I mean, obviously I wanted to experience the culture, I wanted to learn about it, I wanted to help out, but I can't say that it was entirely selfless.
I mean, there's these conflicting motivations. A lot of times people genuinely have a desire to work with and for communities, but there's also people who want to have a cultural experience, who want to pad the resume, who want to secure research funds, who want to get into a professional school. That's a big one as well. There's a huge, there's a either a perceived or a real need to have these experiences. There's often a section on med school applications or dental school applications or even law to have these experiences where you've engaged with vulnerable communities before.
What Liz and Allie describe is what many of us who travel to do medical work in developing countries may be afraid to admit. Not only do we want to help, but we want to see, and we want to experience the exotic. And despite our wanting to do good, we may not be aware of the consequences of our actions.
And so often we prioritize, oh, having an impact, go and you'll have such a great impact. And then you don't have the qualifier of what kind of impact you're having.
So you can look at, when we talk about medical tourism, although there are many different definitions to that term, the way that I'm using it right now is to think about short-term medical interventions that take place in resource-poor settings and are led by health professionals that come from resource-rich settings. So, in particular, when we look at medical students involved in quote-unquote medical tourism, we're talking about medical students that participate in the direct care provision for patients in resource-poor environments when they're coming from a resource-rich environment.
Another part is the what I call medical voyeurism, where we go to observe other people, and not necessarily, we go as tourists, not because we have a commitment to that community, but because we want to see. And that's kind of like people stopping at an accident site and watching and not doing anything to help. And to me, that's really disrespectful of those cultures and those communities, and that's one thing that I would like to see change. And I think the way to do that is to have educators basically take responsibility and start thinking about ethics and think about, would you want this in your community? Would you want people coming to your emergency room, for example, just to see trauma victims and to watch and see what it's like? Or would you want them there because they want to learn and they want to help?
I once had an experience in Tanzania where there are students who wanted to go into the labor ward because there's so many births there in comparison to what you'd see here. And I let my colleague know this at the university that we partner with in Tanzania, and he said to me very directly, he's like, this is not a zoo. And that was a real wake-up call for me, and it was a real wake-up call for the students to say, okay, this isn't a zoo, this is not a place where you can look in on things that you wouldn't normally be able to see. And I think that, any human's privacy and dignity and all of that should be respected no matter where you go. And I think sometimes it's the concept comes along that I'm going to a developing country, so it's okay. They won't.
Okay. So initial thoughts.
That's actually a really interesting perspective because usually when you think about any medical mission or volunteering in another country, it usually has this really positive connotation, oh my gosh, you're doing so much good, but it's for such a short period of time. That's a really strong point. In reality, how much are you going to achieve in that time span? And it kind of makes me think of something that we talked about in one of the sessions, I think, in the fall, about the consequences of, I think we're talking about internationally, I don't know if you remember, the downstream effects of all those things. And so I really like that they present that perspective, that it's not just there to because you're just going there, like they said, tourists. You're there, I'm just going to be here for 1 week. It's not like you're part of that community, part of an entity. And so I thought that was interesting.
Yeah. Anybody else?
That's something that we sadly are not aware of. I guess disabilities sometimes may have to motivations or actual effect
another hand over here.
Oh, I just thought it was interesting because, like, that was the description of like discourse to MD, and like that was what was told to us. Like, oh, you can do like weekend trips, like down to the border, or like you can do like over break, you can go on a 2-week trip to whatever, and like we talked about this early on. I feel like we've like touched on this in a couple of classes already. But like I've gone when I was an undergrad, I went on like alternative break trips to Peru and South Africa and did the same thing, and I've had like mixed feelings about it too. And for like medical whatever, but it wasn't so much like a drop in and help and get out. It was like we started in Department for Special Education in school, or like started a clinic up and like things like that, where it wasn't just like like I felt like it was actually like the start of something or like participating in something. So it's like I feel okay about that, but it is some of these like I think are kind of like frustrating where you drop in just to like and I don't think all of them are bad.
Yeah.
So I felt like this was like a really negative side of that. That was where like I don't think all of this is negative.
Yeah, and I think that it's important to know what the extreme looks like, so that you can, one, avoid it, and two, figure out, okay, how can we make this sustainable? How can we make an impact? But to know that at this level in all of your training, there's very little that you're going to be able to meaningfully do or provide. So when you go abroad in the context of your training, it's going to be it's going to be transformative for you more than it is for the population you're serving or the community that you're serving. And I think that's an important takeaway. It doesn't mean it's always going to be that way, but I think being cognizant that at this stage, what you may have to offer is incredibly limited. And to make sure to be insightful enough to kind of know what your impact is or isn't. This is not a zoo. It like resonates with everybody. I like this guy.
You have it on some website, someplace. Those ethical issues that come up. It's not as easy as people think, because you go to that environment, you have your camera ready, and you see these things. I must have a picture of this, and then we forget all of the things that you would necessarily have to do here. And that is the greatest danger. That students feel liberated once they get to these environments. So all the rules and regulations that limit your access in a country like this, you suddenly feel liberated. You can do anything you want. And sometimes in some of these countries, the gentleness of the people there, and so they don't want to tell you that you can't do those things.
It's very exotic to go abroad, and this gets back to the medical tourism thing. There's a lot of people that really want to travel to the world, and that's great, and people should do that. They just shouldn't do it under the guise of going somewhere and helping someone for a week or two, in an unsustainable kind of fashion. I think that there are lots of questions to ask, and I think that students also really need to ask themselves those questions about what's their motivation, why do I want to do this? Is it for my CV, or is it to truly further my knowledge of global health? Is it vacation? And it's okay to do a global health experience and also put a vacation on it, but the global health experience is not actually a vacation. I think that's what students also need to realize. So the question of whether, when you're working clinically, whether you're going abroad to see exotic diseases, just to talk talk about them at dinner parties or in the presence of colleagues, or just to have that kind of experience in your back pocket, versus going abroad to get exposure to things that you're actually going to subsequently utilize. Global health within the larger world of aid is entrenched in moral presuppositions, making our motivations to engage in it very difficult to question or to contest. But asking why we choose to participate is essential. Despite good intentions, working in under-resourced areas may not be a priori a good thing. Questioning can be very uncomfortable, and the answers may be unexpected, especially when the ethical waters are muddied by competing motivations.
Like what is the reason that you're going over? Like, what are you hoping to achieve? And by doing so, are you causing more harm or are you doing good? I mean, all of us come with the intention of helping out, and that's what we really want to do. But when you really stand back and look at it, like, how much help are we really doing?
When students come in and they say, I want to go overseas because I want to make a difference, I have them break that down. What does that mean? What does a difference mean? What are really your learning objectives? And maybe those learning objectives can be met within Canada. You know, you don't necessarily need to go overseas. So it's really looking at what the learning is and what would be the best environment for the student. And that learning environment, like I said, maybe here, it could be overseas, but being very clear about the learning objectives.
The other aspect is that when people are coming with a service mentality, they're typically accompanied with good intentions. Something I like to talk about is that good intentions are insufficient as a premise from which we can decide to pursue these global health projects. Because just because we have good intentions doesn't mean we have the experience and knowledge, the breadth of worldview to actually contribute something of value.
Even our best intentions to help may be based on a paternalism created by the Western media barrage out of Africa and other developing regions that creates an image of vulnerability and need among the people exposed. It demands that we help them, a moral imperative.
One of the things we lack the most in the healthcare professional, among healthcare professionals, is humility. You know, you go to a remote area and the young doctor knows as much as you do. And you wonder, well, I have all the books, I have all the journals, I have internet at my beck and call. I have 100 senior doctors teaching me. This guy has one person. And he doesn't have internet, and he doesn't have the journals. How did he know this? You know, and you come back with that humility.
And I also believe that one of the biggest learning opportunities is realizing that in a developing country, it's not all poverty. That we have an incredible number of partners with experience and training that is above and beyond our own experience and training. So one of the pieces that students learn is there are great partners, and they are there to learn, and they will gain a lot through that learning experience. And that piece, I think, surprises many of us.
My recommendation for medical students going on electives is to consider it entirely as an experience of education rather than an experience of service. Because I think there's something important to say about an approach. And if you go into an experience with the expectation that you are going to help or that you're going to serve a particular population, I think that removes an element of your humility.
I guess the point was that we're...
Thoughts on that?
I feel like that's really contradictory to what they're trying to say too, because they're saying don't use it as like a medical vacation, like use it as something that's sustaining. But saying that you're going just as education, that's not sustaining if you're just coming back and educating yourself on things you'll never see over here in the United States.
I think what a lot of these programs they send students, but they also do a lot of other things. So I think what she's talking about more is the student perspective of things.
Okay. I think the ultimate goal is to go, if like you're going to help, well, then you need to go with the basis of educating the people that are there all the time, the people that live there. Like educate, if you want to go help because you think that your skills are superior to someone else's, well then teach them your skills so that they can do those skills because they live there. You know, so I think that we're missing the component too of like if you're going over there to learn as a student, then learn as a student, learn the culture. Go over there and learn everything you need to learn in that 1 week that you're there, because when you graduate and you're practicing, then you can go over and make the difference. And people will listen to you. I believe, this is totally my opinion, but I believe that people will listen to you more if you've been there and are able to approach them from the stance of, I've been here before, I've been learning about your culture, I'm here for more than just a week, I'm here to teach, and like to leave something that's sustainable, you know, by teaching the people that are there so that they can continue on whatever it is you're doing.
Right. And that's kind of what we call capacity building, really. It's the whole idea of, you know, feeding a man a fish, you never get this right, or teaching a man to fish.
Oh, I was just going to say that, you know, I think looking at it from the perspective of learning both about medicine, the culture there, the experience, taking it from, I guess focusing on that pulls away this concept that, well, I'm coming here to save you.
Right.
I'm coming here to do something that you can't do for yourself. And being one as students, that's very, very presumptuous and very high-horsey, and I think we should always be going in as students, as providers later on in life, hopefully, you know, as I'm here to do what will help and what will benefit everybody, not just my sense of wanting to do good for you or my sense of coming in and giving aid. I think one of the presentations from the fall talked about how sometimes there can be a detriment to aid because if we're just bringing these resources and we're not bringing with it the education or the system that's behind it that was so successful here in the U.S. or successful as we're qualify it, we're not really doing good. We're going back in that cycle, just satisfying our need to feel like we've done good.
Right. And I think you're right. It's not just kind of keeping that perspective in mind as a student, but also kind of throughout your career doing global health work. Because you may come in, when I was in Botswana, we had somebody come in who's a cardiothoracic surgeon from Penn, and he's like, I'm going to teach people how to cath. And we're like, great, we don't have a cath lab, and nobody asked you to come to do that. So I think he got deflated a little bit, but then we were able to have the conversation with the folks that work at the hospital, like, hey, we have access to a cardiologist for a month. Is there anything that you want him to do? Is there anything that, are there any skills you want to brush up on? And then he ended up doing, just putting together this great ultrasound course, and everybody brushed up on their ultrasound skills. So it was, but you know, he adapted to that very well. But I think that there are some folks that come in with that mentality, and it really does rub people the wrong way. Also, the diseases that we see here are very different from the diseases that are in a lot of these places where there may be a junior medical officer who hasn't done residency and, you know, doesn't have all the expertise that you might have, who's actually way more knowledgeable at treating something than you are because they've seen it a million times. So really having that humility of being able to really collaborate and work with people instead of thinking that you know what they want or what they need. Any other comments?
I'd argue that the premise of this video is no loss. It seems like they're really attacking students' motivations for wanting to go abroad. I would argue that the bigger reason for why they're having issues is people wanting to go and hang out in a labor or watch birds all day or look at it like a zoo. I think it's rooted in lack of respect for the culture that they stem from. Coming from a resource-rich environment, going to a resource-poor environment, there's disparities in financial resources, education. and this might be an extreme, sort of like a God complex. You know, you go in thinking like, okay, you know, I know more than you. I have access to more stuff than you. And I think they overlook those basics.
And I also kind of have to agree with that and kind of argue against him of the fact that, like, something has to, not everyone is like this. Some people are driven for particular reasons, and if that drives a person there to begin with, because they're like, hey, I wanted to see this country I've always heard about it, I wanted to see what it was like, and it drives them there and then motivates them in the future, I think the job was well served. You know, and so I think that they kind of missed that point too, because if you try to tell someone like, you can't go there because you want to see anything else, if you can't go there because this, you're not going to get anyone there. I mean, that's just like the root of it, you know? So it's like, it's kind of one of those things where it's like, is there probably selfish reasons? Yes, but does good still come out of it? Yes. So.
And I think the point is to be aware of those, not to dissuade people.
Right.
Because, you know, global health to me is very similar to conservation efforts. Like, if you never witness it and you don't feel connected, you have no stake in it. So I think that there's definitely a role for students at this level and even younger of being involved. But I do think that we need to be clear with what our motivations are, and it's usually more than one. It's a lot of those things.
I mean, it's just as simple too as like they brought up, like, it's in your backyard. I mean, there's always like that old saying, like, there's certain areas in your neighborhood your parents always told you like never go to, and if you went there, you would be like, oh my gosh, like, I see why, you know. And that happens here in America, like right in our backyard.
So I think we're gonna wrap up with this in a little bit here. Let me see. Just like this. Just keep it around.
In another environment.
And I believe that it doesn't have to be medical violence. Right? I think that there is no such intention. I don't think that when it happens and it falls smack into the confines of medical barbarism, that nobody intended it to be that way. It's just taking the opportunity that you didn't expect that you would get this opportunity. You know, you're a second-year student, for example, and you end up in a country like Guyana, and the surgeon is more than willing to kick you into the theater. You know, they're doing open heart surgery, and they let you in and allow you to start handling things, and so that wouldn't happen here. And you start looking into things, you start taking pictures and so on. These are the reasons why it has to be structured, so that the students and the facilitators understand the parameters within which we work. Whenever these things happen, that we can call medical barbarism, some people call them cowboy medicine, or something like that, it's because we don't work with structured elements. We do not have the parameters established. But let me just say that quite unequivocally, there is always benefit to anybody with any kind of health literacy, whether it's in medicine or counseling, lifestyle choices, health promotion, whatever it is, there's benefit to such persons being in various communities, particularly the developing countries where they don't have access to all of the resources that we may have in developed countries. So I want to say that quite clearly, that as a minister from a developing country, I believe there's huge benefits to be derived from students, faculty, experienced healthcare providers from one environment to come join us. Oui, je pense que c'est très très important. Ils doivent venir parce que un jeune étudiant qui passe toutes ses études en Europe ou bien au Canada ou aux États-Unis, parfois il ne s'imagine pas que quelque part dans le monde, la médecine existe dans de mauvaises conditions. Donc, ils doivent arriver. Un bon médecin, c'est un médecin qui doit s'adapter à toutes les conditions, mauvaises ou bonnes qu'elles soient. Donc, c'est important qu'ils viennent parce que je sais, un médecin, il n'est pas seulement un médecin d'Europe ou du Canada, c'est un médecin du monde.
With all the questions and ethical pitfalls, a moratorium on medical student electives and projects in developing countries might seem inevitable. But the growth of perspective that comes from witnessing how others live outside our own experience, and the development of a sense of social responsibility to the health of the world, may be one of the most important reasons to continue supporting medical student global health programs.
I mean, we are part of a global village now, and I think that we're not simply training physicians and others as insular individuals in their own environment. Yes, perhaps our first responsibility is to the people of the Maritimes, for example, in developing a cadre of competent physicians. But I think the way the world is going, that's not enough, that we need to do a lot more, and we need to have more of a sense of responsibility overseas.
Well, the world is a village now. What happens in Africa would soon, in one way or the other, get into Europe, into America, into Asia, etc. So knowledge that is available in Africa should be shared as well to other countries.
Because if you hear about HIV in sub-Saharan Africa, it's different if you are here and see the problem and try to help to solve it. So to me, I see that it's very, very important for other people from outside sub-Saharan Africa to come and try to help.
I think for me, you don't really understand the problems until you see it with your own eyes. You can watch it on TV, you can see pictures in the movies. It's just not the same until you get here.
I mean, at least as a medical student, not as a doctor, it's very little to do with altruism, in the present at least. I'm not saving anyone's life. I don't even know most of the drugs that are being prescribed to these patients, so I would be completely naive if I thought I was making any difference at the moment. But I think by gaining this experience, hopefully down the road I can be better prepared to serve a community like this.
So I think that echoed some of the optimism of why people do this and why they should continue to do this. We wanted to do a couple of case studies that placed you guys in difficult situations. And this is not to say that we anticipate any of this happening to those of you that are traveling, but shit happens. And we can't control, anything once you're gone. We had, I want to say in Uganda, we had a student that was just on her way, walking to the hospital, wasn't even there yet, and a woman came up to her and just handed her like a dying child and left. We can't control that. So things happen, and people are put into situations that you may or may not be put into here, and we just want you to think about how you would respond in those situations. So this is our first case. You're on rotation in Ecuador. Your preceptor sends you with a medical intern to a really rural clinic. When you arrive, there are over 100 patients waiting, and the intern asks you to see patients in one room, and then she sees them in the other. What do you guys think? You're there to help. It would be helpful, maybe. What do you guys think?
It's not my scope. prepared. I don't know about coordinates. I don't think I'm educated enough to do proper patient care without supervision.
What if the intern's like, oh, you got this. You can do it. You gotta learn sometime. Might as well be now.
I mean, if I feel like I can handle it, I would do it. It depends on what kind of patients you're seeing or what.
You don't know. You just got there. You have no idea.
I'd still argue that I would do more harm than good.
Anybody else feel that this is probably outside the scope of what they should be doing? Anybody think, I'm up for a challenge. I'll try it out. I see a challenge.
I mean, it depends on what I'm seeing. I feel like there's some things, like I feel like I've been trained well at that place for my field that I would be like, yeah, I could probably like, see that patient and treat that patient. Because that, I mean, I don't know, I guess I just obviously if I felt like it was way out of my scope and that I would be like causing harm, then I would never do that. But it's like if I saw someone on the street and they were in the same type of situation, I would go help them. I wouldn't walk away and be like, not trained, sorry, don't have my license yet, can't help you.
So what do you think happens when you're not there and the intern goes and has 100 patients to see? Maybe they go unseen.
Quality of care goes down. I mean, I don't know how great the care would be to start with 100 plus patients, but I mean, obviously, even if you get through all of them, it can't have been a very quality, thorough sort of experience for.
So I'll agree, that's a lot of patients. I'm just going to say too many. It's important to think about what happens when you're not there. Because not a lot of times, but sometimes you think you have an idea of the situation and what's going on, but it could also be that because you're there, certain things are the way that they are. That because you're there, the other intern that was supposed to be there is like, you got this, I don't need to go. Or there are other like nurse prescribers who could be there who aren't there, or other people that can do that. So I think it's important to know your scope, your role, and to be able to speak out like if you really feel like, I really can't do this.
Very proposed, for example, like, okay, I can't see patient for you, but here's what I can do instead to help with the workflow.
And that's the third way, like the third option, which is almost always your best option, is to say, you know what, I can't really do that, but let me tell you what I can do. I can help triage, or I can get vitals on everybody, or I can do something that I'm trained to do that's actually going to help you out. Other folks have, to get out of these situations, have made playful jokes, or they joke that the public education system in the U.S. is so bad that we really don't get trained very well. Others just blame us. So whatever you have to do, that's fine. So you tell the intern, you're not really qualified to see patients by yourself. You're going to organize them, triage them by age, and take vital signs. You meet a woman with a small child, and she says that she's here because the child needs surgery to repair a cleft lip, but it costs $100. She can't afford it. She asks if you can help pay for her child's surgery. What do you do?
I feel like if you agree to that, that could lead to a bunch of unintended consequences. And so maybe who could you talk to at the clinic that might be able to help rather than going that route? Because then if you help out that one person, how can you say no to someone else? So that seems really.
What are the unintended consequences you're thinking of?
Well, let's say you agree to do this, right? And then it's fantastic, and that child and that family gets helped. But then, are other people gonna come with that expectation that, oh well, I asked one of the students and they helped me, and then it just creates kind of a murky situation, and then it's unfair for everyone else, and
And then what happens when you leave, when another student comes? What is the expectation going to be? So is there anybody that would say, you know what, $100 is not a lot, to us, and it's going to be transformative and life-changing for that child. And I may not be able to do this for everybody, but I can do this for the person who's standing in front of me.
A way to go is we can do that, but then also attention, like from the unintended way. It's like not really make a parallelism, but the closest experience I've had is like, for example, on campus. There's certain things you can do as an individual where you'll be helping a particular, patient or individual, because it's not sustainable, or you're not always going to be there. There are like programs where already organized, if you will, ways of providing aid. One that's more clear, it's more sustainable. So even if it's going to be your $100 that still goes to this child, you can do it in ways not so much very direct, like, oh, here's $100, put it in the can, but perhaps like, I don't have a clear answer, but like, go through a system or needs where it's like, okay, yes, your $100 went to that child, but then there's an entity that people who need the assistance can essentially go to. So for example, if you're Ecuador, right? If you're in Ecuador and you realize, okay, this clinic has like some kind of indigent program, you put your $100 towards that program, and first say, like, this is a program you talk to, call them now, they're going to take care of you. I think that's a better means of that $100 than giving it directly to the individual. And then not having like any sense of distrust or agency, because I don't do something like that. They're gonna say, oh my gosh, that's so helped me. The teacher did it. They're gonna share the news, but then you realize, like you said, you can do so much too. I think it's better. I don't know, it's very good, but if there's a program or something.
So many of you wouldn't do it, but if you did do it, you would do it in a way that kind of went through maybe another organization or something that's much more entrenched and established that can take care of it. Okay, good. So you see a patient together with your intern, and the patient complains of fatigue. While you're in the exam room, she passes out. You rush her to the nearest hospital where she's found to have a very low blood count. She's found to have a bleeding uterine thyroid. She remains unconscious, so your supervising doctor prepares to administer a blood transfusion. The family takes hours to arrive, but they do so just as the blood is about to hang. They order your team to halt the blood transfusion, stating it's against their religion to receive blood transfusions. What do you guys do then? That could happen here as well, so it's not unique. Let's say the patient is a 20-something-year-old.
So the ethical thing is to respect their religion. At least that's like the. That's the
correct answer on a multiple choice test.
But how do you know that that was her practicing religion?
Yeah, exactly.
So what do you do?
I would get the transfusion. The patient can't tell me, and I don't have anything that says that like these family members, or even her family members, or that they are like able to speak for her, then I would give the transfusion.
Okay, give transfusion. Who's with give transfusion? A couple of give transfusion.
I have a question about the laws. Because I know, for example, here we have laws that we obviously have to find to be knowledgeable of, but like, wouldn't we also need to know like the laws Yeah, exactly. We don't know if their prioritization or like proxy is the same. Like for us, it's like a person's an adult, their spouse, then their parents and siblings. And there's a hierarchy. And I wouldn't know in this country. I would know that.
So what do you do in the absence of knowing that?
Most hospitals here have an ethics board, so maybe it's not something they have some sort of ethics committee.
I can tell you there's no ethics board.
Yeah, I was just going to say, just in those situations where it's gray like that, I would just go with what you feel is right. Like, So I would go ahead and get the transfusion.
Err on the side of saving the patient.
I would hate to basically lose the patient for something that, if the patient, given the choice, would have chosen the transfusion. I personally, I would prefer saving her in, not but there are ramifications for that. But between the two, I would prefer the one where the patient is.
Is there anybody that would not get the transfusion?
That's my thing. Like regarding what the religion is and what the belief is it gonna like she may survive, but then will said family
accept her,
didn't accept her, or like even the community, like where will she have a place to stay? Will she have a place to live? I think there's so much to consider within that too. I mean, we don't know. And that doesn't answer the question because I still don't know anything. But
anybody think of a third option? A middle ground?
Why was she? What was?
Bleeding uterine fibroid.
And so she was like unconscious, right? So there's like no slap to wake her up after that.
You can try to do that.
Yeah.
Is it? I guess that's where knowing more about the routine health. Like, what exactly do they? What exactly, I guess, is not accepted about the blood product? Is it whole blood or parts of the blood? I mean, I know times of essence, but I would like to know that.
It's any different from like any other. It's like anything that doesn't nourish the body.
Is that really? I thought that was.
Yeah.
Yeah, it's different language and different. Different beliefs as to what types of blood products are acceptable.
So we need to know the laws that dictate this locally. We need to know what the specifics are of the religion itself. Could we get around that? Meanwhile, we're likely giving her a ton of IV fluids and like defibrillars and like all the stuff that we can do to expand her circulating volume. At what is there anybody besides an ethics board? How would you actually navigate this in real life?
Probably ask your
Hopefully there's somebody in the room that's going to be making this decision and it's not going to be you. But I can tell you, regardless of what decision they make, it's going to make you feel uncomfortable. Because you're working with incomplete information. And there are instances where patients die. I mean, in many parts of the world, this woman wouldn't even get transfusion, even if she had it, because their family needs to come, pay for the transfusion, and then it gets administered. So lots of people die kind of waiting for their family to show up so that they can pay for the transfusion. They do that in Kenya, in Dominican Republic. I was there, a long time ago, but we had patients sitting on the wards with hemoglobins of 2, waiting for their family. So a lot of the practice of medicine and the rules that dictate it are very different in different types of settings. So a lot of times our students, that's probably the most disorienting thing, is watching people not get what is standard of care and having a complication or dying because of that. So here she's in an emergency situation, you're at a place that can give her those products, but some of you are going to be in places where you know what the treatment is and it's not going to get given. And that's just painful to deal with. So you agree to give IV fluids and iron in preparation for surgery. The supervising doctor lets you observe. You notice that he touches several non-sterile objects in the OR during the surgery. She goes to the hospital floor, is stable, but several hours later is noted to have a significant fever. What do you do now?
Something that she gets antibiotics.
Definitely she needs some antibiotics.
So, would it have been appropriate, because I don't know the answer to this, but would it have been appropriate to say something during the series in terms of thinking? In my opinion, we saw the mistakes of it. Wouldn't the, I don't know, would it have been appropriate to have said something that at the same time? Like,
So describe to me what you would say.
I'm not sure, but perhaps I'll take the approach of, oh, I noticed you touched that, like, do you call it, like try to ask the question unassumingly, because I'm presuming it's not down. Maybe it was, and I missed something. So just like we share, like, oh, like, is that sterile or like or something along those lines. I know it sounds a little off, but
Can I get you a fresh pair of gloves?
yeah, or something. Yeah, just to like help, because I feel like at this point where she has to fever, like, I mean, other than doing it, like it's too late. Not too late, but
It's already happened,
yeah,
right? Yeah. So, what do you guys think? How would you address that intra-op? And if so, how would you?
I would have done your way. Do you need fresh clothes instead of being
yeah, I didn't
upfront
know how to
about
ask
it?
the question.
Any other ideas on how you would address it?
I just say, I'm sorry I didn't see that that was sterilized. Do you mind if I sterilize that really quickly?
So it's actually, I mean, you guys are doing great, but it's really hard in the moment to think of any of those things because all that you're thinking is WTF, and the words just don't come out of your mouth. So to take a minute to think about, okay, how, given your level in the hierarchy, and medical hierarchy in some of these places is way more pronounced than it is here. So knowing kind of your place in that hierarchy, but knowing that you see something and really need to say or do something, it's important to think about how you would say it. Or is there a medical assistant that's there that you can say, hey, do you mind getting more gloves? Or kind of using your network of people around you as well. But this is something that has happened. Okay, so she gets worse. Her blood pressure drops. She needs IV antibiotics, obviously. But she ultimately passes away. You mentioned your observations to the intern that you're working with. And she says, mistakes happen sometimes, but we don't say anything. He's a very respected surgeon and saved many lives.
Not that one. See, I feel like with that situation is like extra tricky because even if you say it in a very respectful way, there are some people that, like, it's just, they might not take it well. And so in that case, like, I imagine that one of the scenarios, like, he could be like, or she could be like the surgeon, well, what do you know? Like, they might just take it as an attack because they're so not used to having anyone say anything blow in your face.
And there are definitely cultures where debate is very, it's a culture of vigorous debate is good. But then there are also cultures where any kind of dissent is really disrespectful. So how do you navigate that?
I mean, you don't have to get into debate to bring attention to a situation. I mean, you could, it's a difficult conversation to have, obviously, but you could just be like, I noticed when we were in the ER, I'm not sure if you were aware, but your materials actually weren't sanitized, and so I'm not sure if that had anything to do with it, but it possibly could have. So would you mind if I watched a future surgery and I observed sterilization? Kind of putting yourself where you're like, hey, I'll take care of it for this next one, but also bringing up hey, this wasn't done. For me, and also not pinpointing it on that person, this is your fault.
Okay.
You could even, obviously if you don't think about this in the moment, but you could even say, oh, I think I might have actually accidentally touched this to something non-sterile. We might, put the blame on you. If there is that sort of power dynamic, they're gonna be, it might have consequences, but, you could also try to say, like, well, I think I did this, so it kind of pulls the focus away from something, an error that particular person.
Mm-hmm.
Speaking of lenses, like, I know that, for example, here in the community, if you see something that's not right, we have these artists that go about it. There's a
Really?
well, in the sense that, like, for example, I mean, in the sense that, like,
do I have it too?
Like, it's not very clear. It's kind of like, it's not an algorithm per se, but like if you do see something inappropriate, we're trained or taught that there's a way to report or a way to kind of go about it. That makes a bit of sense. And I think again, knowing more about the culture and knowing what the systems are in place. Like, for example, there might be cultures where it's like, okay, you may not necessarily say something to the surgeon, or okay, maybe you talk to someone else. Let's say there's someone on the hospital board who tracks, for example, post-surgical complications. I don't really know, but I mean, the point being, just kind of knowing your system and where you're working, and knowing what the modus operandi is here, if that makes sense. For example, here it's like, oh, this is who you talk to, or this is already what's being done. And they already track post-surgical complications, so you don't maybe necessarily have to say anything unless they're like, oh, what did you observe? Or what did you notice? Or we noticed, okay, the surgeons have been having these complications. What's the trend? And that's where you offer your assistance or whatever. Or some hierarchies where we talk directly to the individual, and if they don't respond, the hierarchy move up. Like, I think again, just be more knowledgeable about where you're working within that system.
So here anybody can do an adverse event report, and it could be totally anonymous, and you could do it online. So, we have a lot of mechanisms, like you could do it in person, you could do it via email, you could do it with this anonymous thing. Most resource-limited places don't have like a mechanism necessarily for that. But I think it's important to know what your local resources actually are and how these things are managed and handled and who advocates for that. And chances are, if you're noticing this, other people are noticing it as well. It's unlikely to be an isolated one-off kind of incident. So there are lots of ethical. This is like a tiny snapshot of the ethical issues that people can get themselves in. So I think that it's important to ask a lot of questions about the structure of, okay, well, how is this done here, and how is this done here, and who does this, and who does that, and so you have a good idea. It's hard enough to know that in our own hospital, which takes years to kind of figure out, okay, who does what, and how things are done, and how they fit together. So it's even harder in a resource-limited setting, where some of those things may not be written out policies. It may just be so-and-so always does this, so we let them do it. So knowing your environment, knowing who all the key players are, and knowing who you can advocate, who you can talk to about this locally. So your preceptor, people at your site, the other students that are there with you. And then if there's something really egregious, we had medical students that were being asked to do deliveries. And that was an immediate call to us at 2 a.m. and we handled the situation. So you always have an out. You can always blame your institution. I do that even now for all sorts of things. But think about what your outs might be and how you would approach people, because you may or may not ever need to use that, but sometimes you do, and it's good to have it in the front of your mind. And if there's something that gives you the heebie-jeebies and you just feel really uncomfortable, pay attention to that and say, you know what, maybe I'm not supposed to be doing this, or something about this makes me feel uncomfortable and I need to evaluate whether I should be doing this. whether somebody else should be doing it, if I need to remove myself from the situation altogether. There are also other cultural norms that that can be very gender specific as well. So we've definitely had issues with women traveling places that are where they travel without other students and then they're there by themselves. That the way that they're seen is very different than like a group traveling together. So sometimes we've been admonished by our own collaborators for sending women by themselves. And the relationships that you develop with people on the ground, it's important to keep in touch with them and keep the lines of communication open. But use them as resources because they will know, they will tell you like, oh yeah, I wouldn't go near like so-and-so, or, this is the best person that's going to be able to teach, or they'll help you kind of navigate some of these things that can be a little tricky. So, so one of the kind of important things for those of you that are traveling, the way that we circumvent medical tourism is really having you go to work on a project that our host collaborators want you to work on. So we meet with them and ask them, okay, we have a student that's interested in coming to your site. What do you want them to work on? If you had essentially free labor, what would you want that person to do that could help you, help your project, help your organization in a meaningful way? And that's how we come up with these projects, knowing that you guys aren't really going to be super competent in a clinical setting, but you can always do chart reviews. You can do QI stuff. You can, we had a hospital that said, our post C-section infectious rate is high. We want you to, we think it's high, we don't know. We want you to do a chart review and figure out what the rates are and then present that to us. So they did, and then based on that, the board made certain modifications to like how they normally do things in the OR. We had a group of students who happened to have an economics background, and one of the mission hospitals said, we have all these donors who donate, X number of dollars. They want to know what the return on their investment is in terms of number of patients seen and medical equipment. So they were able to tally all that up for them, and that they were then able to take that information to their donors and getting more money for the hospital. So there are ways for you guys to meaningfully engage. And I think, as you get more entrenched in your training, and you're going to be even more and more capable in these kinds of settings. So it's a marathon, not a sprint here. And this is, many of you have already gone abroad. Many of you have lived abroad. So it's just kind of baby steps of getting you guys to where you need to be. Any final comments before we close?
What happens to the girl in Uganda who got that sick child?
So we partner with an orphanage there, and they were able to kind of take care of the child while the police found her parents. And she got admitted to the hospital and got treatment and all that. So she ended up doing well, but her family thought that she was dying and she was going to die, so they never came back to look for her.
What was wrong with her?
I don't really know. I don't remember. I think it was something infectious. Okay, thank you guys so much.
Oh, you want to go out? Okay, hold on.
Is there an indefinite comment? Yes. Okay. My name is Jay. I had some questions, but I'm now forgetting them. Basically, I wanted to talk to you. Well, first I would say I'm in Crossroads Scope, and I'm going with this coming as a cohort. And so I was talking to like some of my other mentors just about like long-term career planning. And I wanted, I guess, in regards to the trip to Nairobi, I'm still not really sure what my project's going to be. Did we find out when we get there, or?
So there's some where we figure your project out for you. Nairobi is hard because we don't always have.
I was wondering if I could talk to you after you.
Yeah. We don't. We work with a couple of faculty at the University of Nairobi, and they help develop the projects, and they have like lots of different things. So it probably won't be until you get there.
Okay.
I mean, we try to get it set up before, but there's a lot of uncertainty. And actually, I want to say last year, the year before, Dr. Lois wasn't. She just wasn't there for the first half of it, so the students were trying a little bit until she got there. So it'll probably be when we get there, and it is likely going to be a little unorganized. Just to
all right.
Plant that seed.
Plant the seed. Yeah. All right. And then in general, if anyone was like, because I do have long-term health goals that I would like want to achieve, but I don't exactly know the roadmap to like how to do that or how to be engaged. Like for example, my biggest like research interest is in essential surgeries, just like to improve quality of life here. Because like, for example, my family's from Nigeria, and like basically motor vehicle accidents are like such like how do I put it? The fatality rate is so high, you know, where like the first thing you ask when someone gets in a car accident is like, are they still living? You know, kind of thing. And so like I don't exactly know how that fits in like my long term. Like how like the type of training I'll pursue, for example, after medical school, or you know how exactly to place myself where I could essentially in the future be able to like establish programs that train mid-level providers to provide these essential services. So basically, an analog to like how we're meeting our primary care needs.
Right. Locally.
Locally, exactly. And so essentially starting that, not starting, but aiding that kind of effort so that it's not just that surgeons go over there, they do their surgeries and then leave. Right? And so I was hoping to have the opportunity to talk to you at some point in the future.
Yeah,
how would...
I like to eat, so let's do lunch. Okay. And then we can talk during it. A couple of things come to mind. What you're referring to is kind of pre-hospital care and trauma care.
Yeah.
And that's lacking in many places.
Of course.
I have
and then OB too. Like there are too many like obstetrical complications, surgical ones that are just not met.
So I can put you in touch with some people who work on those things.
Okay.
Not they work on those things maybe in other places, not necessarily in Nigeria, but other places.
Yeah, I mean the training would be essentially the same, working in I guess in places that don't have as many resources here.
But I think that you don't necessarily, it sounds like you're trying to work backwards from a vision of what you want to do, and then what's training that
kind of.
And I would just at this stage ask you to try to stay as broad as possible, because a lot of times the people that are actually doing that work have an incredible variety of backgrounds. So there are public health folks that are developing that infrastructure. There are academicians doing it. There are surgery. So it kind of depends on how exactly you want to fit into that puzzle.
Yeah,
but it wouldn't be too niche too early.
Yeah, see that's the other thing too. So like I also have a desire to go into like surgical oncology. So it's like I'm not really sure how my desires could coalesce and come together. And so that's where I guess you come on.
Okay. So email me and let's find it.
Okay. Thank you so much.
No problem.
Hi, I'm Sarah. I didn't have my placard. I'm a PA student.
Awesome.
And I was wondering, I mean, I know you're part of the channel that's helping with the transition into the medical school, or like quote unquote.
Yeah.
I don't really know how that's going.
Has Larry Herman given you guys an update on the transition?
It's not this week, since we back to school. right?
Yeah, I don't think he's here right now.
No,
so,
he wasn't at we had a faculty RT with there, so I assume he's not going to speak.
Yeah, he's not, but the last meeting they had, I can tell you not much was decided. And so I think whatever this transition is going to look like, my opinion is that it's likely going to be slow and in stages, which is good because then we have time to be slow and deliberate about it and not rush to things. What I've told Leary, Dr. Townsend, Dr. Jacobs, like pretty much anybody who will listen to me, is with the transition, there are a couple of things that need to stay within the autonomy of the PA program, and that is their budget. So nobody else has their money grubbing hands on the money, and the administrative structure. So I think that the first part of it is just going to be to figure out like what the physical move would look like. Right. And then the second part would be, okay, what are the processes that need to be in place? And then probably way down the road, we'll look at, okay, how can we integrate like medical school training and paid school training better?
Right.
So I really don't foresee this impacting you guys at all. It'll likely impact next, because you guys are then going to be in clinicals, it'll impact like the next cohort of students that are coming in.
Right.
But I mean, the curriculum itself, I don't really think needs any changing. I mean, people always tweak their curriculum every year, and that's great. But I mean, with the board pass rate, with how well you guys just typically do, and that you're really clear broad. So I don't foresee there being huge changes at that level.
Yeah. Do you think there could possibly be an increase in the number of, because the only international like rotation that I've ever heard of is the one that goes to Guatemala, which isn't a bad, I mean, it's a great opportunity. Do you see any possibility, because I know the medical school has several more, like with being a part of the medical school, I know it's like 2 to 4 weeks versus a much longer period, which even goes even further to the whole point of like.
But you know, we've been wanting
medical
PA
volunteering.
students, and the big issue has been like, it's not anything with her sites. We can figure that out, but we need a PA faculty to kind of be committed to go, and we need the program to support them going.
Right.
And we need a way or a mechanism for you guys to get some sort of stipend, scholarship, something, because we do tend to give, I mean, they're not huge, but some scholarships to the medical students to cover a little bit.
Yeah.
So those are really the big issues. But we would love to have PA students.
Yeah.
But it's, you know, when, gosh, who was before Marcy? It was before you were here, Jennifer. One of the previous, Jennings, one of the previous PA faculty was like super involved and super invested. She actually kind of started the global health stuff in the PA school. Once she left, it died down a little bit. So I think we also need kind of faculty that's not only committed, but whose program allows them to be gone for that and support it.
Yeah.
You know, some of the OT faculty, like they take vacation to do this, and that's not going to work. I mean, they're going to be gone for longer periods of time. And then I was talking to Ms. Ashford yesterday about kind of the electives and where they are, and if there are blocks of time in the second year schedule where we could like have some flexibility.
Yeah.
So I think once we get, you know, once we're off probation, step 1, get off probation. Step 2, then I think we'll be able to start doing some of those things. And there will be opportunity for PA alums of the program too. But it is like very baby steps. Okay, we're just surviving right now.
Yeah.
And once we're off probation, we can thrive. But it's just.
Well, I know that. I think in the fall, you know, the fall is so hard, and we start with so many PA students, and then it goes down to like
Yeah.
But I think
But
maybe if
that's okay,
they're
because then they're like, you know, the super
Kinda-
committed ones. and
right.
Maybe that's the prereq for being able to do global health or something here.
I think that would, well, one, that would also help, but two, I think maybe having more opportunities. Like I said, nothing wrong with Guatemala. I think going and getting any sort of international experience is beneficial, no matter whether you're interested in that location or not. But, you know, it's kind of like, as I think someone pointed out, if it's not somewhere you're interested in, then, I mean, if the interest is, I mean, at the end of the day, if the interest isn't there, then you're not going to get as many people to go out there. So, obviously, way down the line.
Yeah.
But I know there's probably lots of people interested.
And there are folks from other programs and schools that are interested as well. And what I would love to do, if we could get this idea to get traction, is to have like an interprofessional team, an interprofessional global health team that gets like deployed to these places, and they're there together with like the cohort of students and everything.
Right. Anyway, just want to get your
Yeah.
opinion on that. Well, thank you. No problem. Thank you. How's it going?
What's up? How are you?
Good. Do you know that I'm gonna Ebola initiate you?
Yeah,
That's
because
cold.
I do too. Well, I'm getting over my cold, so.
I'm just sorry.
It's the cough right now. That's all the. It sounds worse than it is because it's like the end of it. Just like all the mucus.
That's when you just have like the worst voice. Actually, Nipa is coming this weekend.
Oh, seriously?
We're renting a beach house.
Oh, nice.
And she's coming. You know her sister Neha.
Yeah.
And her family, and then and her parents. So we're
awesome.
We decided we don't hang out enough.
Yeah, that's
So
kind of what happens.
You know what? Every other month we're gonna travel to each other. So I went over for baby Jane's birthday party 2 weekends ago. So now they're coming here.
Awesome.
Awesome. You should come and hang out.
I'm not gonna really be around.
You're not gonna be around. You sound
Studying. Yeah. Like Steph is perfect right now. Yeah. I'm like out of commission until like Saturday I take a practice test, and then Sunday I'm usually at home with my parents. Weekends, this weekend is.
Just think about like after your practice test.
Just
to hang out for a little bit.
I might text Nipa then. Because I was talking to her and I was like, we have to hang out after Step. Because she's taking her LSAT, and we're actually taking it within like 2 or 3 days of each other.
Oh, really?
Yeah.
Awesome.
Yeah, so I was like, we should definitely catch up. But I might text her and say, hey, like, after my practice test, I might come through for a little bit.
Yeah.
What are you guys doing? Just hanging out?
Yeah, we have no plan. A lot.
That's
Yeah.
smart. Okay, so you're in Jamaica?
Yes.
Okay. Yeah, maybe I'll come through.
Okay.
I'll text you. But
we can talk about whatever.
oh no, you're good.
Let me just make sure that this mic is off.